talk about Achilles tendon rupture. And you guys were so good in knowing which Achilles tendon had the strain to it, right? So let's get back to it. Ankle tendon fracture, fracture. There it is. Yes. So which one's got the Achilles tendon? Yes. Super duper. All right. Certainly got to see a physician. It feels like somebody just comes up and just hits you in the leg with a stick. Not too fun. Now we got to talk about the peroneal tendon, right? This tendon is probably injured more than what people think it is, because people say, "Oh, well, it's on the outside of the ankle, so it's got to be a sprained ankle." Yes, it is. It's got to be a sprained ankle. Slow down when you're doing this. All right. So you go and you check your anterior talofib, your posterior talofib, you check in the calcaneal fib, and all three of them are right next to the peroneal tendon. So your anterior drawer test and your talar tilt test will tell you, do you have laxity? Is it loose? Because the ligaments is what makes it loose, right? Right. And then add another test. I don't know that there's a name for it, but give them some resistance and have them push out and up. Push out and up. I want you to go just like that. All right? Go there. Very good. And then have them go all the way there, and you push against it and have them hold it out there. All right? So I want to bring it down. If you're finding that the pain then is actually coming up the back of the fibula, you probably have a peroneal tendon strain, which makes a whole lot of sense since that is the function of it. And when you start to sprain your ankle, your brain sends it down, says, okay, fire, boom, and they all get together and they fire and they try and keep you from coming in. So it's pulling against it. So if it's too much force, then the tendon gets a strain to it. Hopefully, that's all you get. I'd rather have a peroneal tendon strain than what I would have to have a sprained ankle. So you see these in obviously wrestling, football, skating, basketball, soccer, just about anything that there is, tennis. All right, and you can have a tear of the peroneal retinaculum, allowing the peroneal tendon to dislocate out of its groove. So we look at this ankle right here. There's a groove, and that tendon runs down underneath that groove, so it's out of the way of those ligaments that attach. And there's a little piece of tissue that holds it down. Because if it doesn't, just like if we're pulling on a rope, it's going to keep straightening out until it finds the end point, and then it gets tight. And that's exactly what would happen here. So the muscle would tighten, and instead of it coming down, making the turn, making that left hand turn and coming down and attaching under the foot, it's just going to want to go straight across and go straight to the attachment point. And that causes that tendon then to jump over on that to that malleoli. And when it does that, it's not fun. But we're going to see somebody who does that. So they complain that when they're running and jumping, the tendon snaps out of the groove. Not that it's super painful, it's a huge nuisance, big time nuisance. And then it jumps back in when you release the muscle. So compression with a felt pad or horseshoe. So you can take a horseshoe or put a piece of felt pad and try and put it behind here and hold it down, but it's not going to work. You can try it, but it's not going to work. It just doesn't happen. And of course, rice and your anti-inflammatories, more than likely, it's going to end up needing surgery. My next door neighbor had that same thing. Yeah, you know that next door neighbor. He's a cop. He jumped off and he was doing bicycle patrol and he jumped off and it tore that retinaculum. He had first surgery and they put a screw in there to hold it down or hold the tissue down that held down the peroneal tendon. Well, his body rejected it, rejected the screw. Couldn't get well, constantly inflamed. They took the screw out, it healed, and now he has no problem. So it finally worked. But this is what it looks like. Peroneal tendon, you see the green part down here, the green and yellow, and then it comes down and attaches way down here at the head of the fifth metatarsal. comes all the way down underneath the ligament and through that, and here's that groove, the superior peroneal retinaculum. So if it tears, you have a problem. Or what is what? You on the outside? Yes. That's actually just ligaments. All right, this doesn't want to start. We'll make it start. All right, so it doesn't want to do it at all. It's all right. I'll show it to you tomorrow. I'll find out how it works and the dealing. But you'll see it, and with this woman here, she was a soccer coach at one of the schools I was at, and it would pop over, and you would actually hear it click every time it popped over. It would click, click, click. And she did have surgery, but it's 50-50 whether that's going to work. So if I got 50-50 or 0 and 100, I'll take 50-50. So anterior tibialis tendinitis. Oh, holy smokes. We got something swollen, right? Because we got itis in there. Yeah, anterior. So it's where? And tibia also tells you that. So yep, it's the anterior tibialis muscle. All right. So what we're going to do is take your foot, you pull it back and leave it and hold it back. All right. You should feel the muscle up here tighten, and it starts to fatigue. It's not a great big huge muscle, but that muscle there is going to fatigue. Now when you do that, so let's do this again. Pull. See how it comes up? Relax. Pull. See the string come up? That string is the tendon of the anterior tibialis. Now, that can get irritated many ways. But how about soccer? Holy smokes, not only are you running, but now you're constantly picking this up to try and kick. Every time you step, your Achilles tendon pushes down to push off, and your anterior tibialis tendon is going to pick your toe up so you don't have drop foot. If you don't, if this doesn't fire, even at the smallest amount, when you walk, you have drop foot, and you don't want to have that. So every time you walk, and if you're walking 10,000 steps in a day, 5,000 of them is on each leg. So point tenderness over the anterior tibialis tendon. We know where that is now. Is that correct? All right. Decrease the activity. Certainly avoid hill work. And the reason that is because if we're going uphill, we've got to pick our feet up even more or we fall. So don't be doing hills or bleachers or etc. Ice pack with stretching before and after running could reduce your symptoms. Get on some Advil and also ask, are they driving? How old are you? Oh, I'm 15. Okay, so how long have you been driving? Because one day you'll learn that when you drive, you don't have to have your foot straight on top of the pedal. And that foot is constantly going to be up and down, especially in city driving. And when you're doing that, that's your tibialis anterior. Now, even more so if you're driving a car with a clutch. This one's pushing down. This one's letting loose the accelerator, and there it goes. Now we're increasing even. We've already gone 5,000. Now if we're driving in a car, especially with a clutch, we went from 5,000 to 6,000 or 7,000 times that we're picking that foot up. It gets irritated. So ask whether or not they're driving a new car. It doesn't matter what age they are, but certainly with teenagers. But let's say that it's someone that's got a new car. Me, I bought a car, and this happened to me. My peroneal tendon on the opposite side, on my left foot, because I bought a truck that had a clutch, and so it was having to work more than what it was used to. Finally got over it, but no big deal. All right, so your peroneal tendinitis. All right, how did this go the wrong way? Was that on there twice? No, that's just the subluxation. This one here is talking about that it gets tendinitis. Complains of pain behind there. Just like we were talking about, the tendinitis can show up. You think you're going to fall, it pulls, it strains it. Now you got peroneal tendinitis. You rice, strengthen the peroneal muscles, and you've seen this in the training room all the time, where they put the TheraBands in and they sweep their foot out. So that's going to help do it. Don't only think about concentric as far as the motion going out. Also tell them don't just let it snap back, but control it back. And that will help the tendinitis just as much as what it is contracting it and pulling against the band. So, gastrocnemius strain. What's a gastrocnemius? Any ideas? We've heard of gastrocs. That's the short version of it. But gastrocnemius? No? All right, let's see here. No. Yeah, you might. All right, come walk with me. All right, we're going to walk on our toes. Oh, wow, now they're showing up. They're gastrocs. That's just the calf muscle itself. You have the gastrocnemius, which is the bigger muscle in the top. Below that is a flatter muscle, and it's below it and underneath it called the soleus. And they both connect, and then they connect down to the Achilles tendon. So this is the main big muscle. All right? Yes, ma'am. They do. He'll get over it. Well, I mean, you certainly are working your gastrocs out the entire time that you're walking, but if they're not falling down, I guess they're doing fine. So variable amount. With a gastroc strain, you get variable amount of pain. We've got a soccer player who's got this. He came in today where he's got that strain on his right gastrocs, and so you can feel either deviations, and when you're feeling for a deviation, you're just cruising along. You put some of the aquasonic gel on their skin so it can slide, and oops, there it is. It's like just like that. You're just cruising along, and then you feel a pit, a little hole, and then around it. Now, if it's the other way around, where you're cruising along and you feel a, a bump, a little like a small M&M or a raisin, about that size, then that's usually scar tissue that they've done this before, and now it's healed, and the scar tissue is not near as soft as what the muscle tissue is. So, if you feel the pit, they've got a strain. If you feel the bump, then they've had a strain, it's healed, and it might, if they're irritated over that, it might be some scar tissue, or it might be where that little bump or the scar tissue has been pulling away from the muscle again. So, but the gastrocs, variable amount of pain, you get some swelling, disability, complain of being hit on the calf with a stick, they got point tenderness and their functional strength loss, they're not moving around near as good. The soccer player we have, he'll complain, and like we told him today, I said, hey, you guys have made the playoffs. We've got to get well. So we're not going to go out and practice hard. You need to chill out on practicing, let the gastroc try to heal, and let's get ready for the playoffs. Even though they've got 2 more games in the regular season, we know that we've made it. Now we got to be smart so that we're healthy and we're able to compete at a higher level. Rice, Advil, heel lift. You know those heel cups? Yeah, put those in your shoes. Make sure they're in both. All right, because we talked about that about my Spanish teacher that walked around in candies all the time. So do that so that their gastroc doesn't have to come as far down to meet the ground. And it may be an elastic wrap, and then your range of motion exercises, and they can do that. Make sure that they're getting full range of motion so that it starts off where they're and dorsiflexion, and then push all the way through to full plantar flexion. All right. MTSS, medial tibial stress syndrome. All right. What is MTSS? Probably sitting there right in front of you. Also known as medial tibial stress syndrome. Think about this. It's also known as shin splints. So shin splints is a catch-all term, and MTSS, medial tibial stress syndrome, is where your muscles are telling you, yo, we need to back off a little bit. Because they're attaching to the tibia, and all of that pounding is just vibrating those muscles and irritating it on the attachment on the long part of the tibia. So I could sit there and I could just sit there and whack, boom, give you one punch. You're going to get a bruise. But if I sit there and just rhythmically for an hour and a half, just tap, sub-threshold, all right, you're still going to get the bruise. Because every time you end up with little itty bitty baby piece of trauma. But you keep putting a whole bunch of little baby pieces of trauma together, they make big trauma. All right? So it's referred to as shin splint, which is a catch-all term. Certainly it is underlined, so I'm sure you'll see this is referred to as shin splints, and you'll need to know MTSS. Caused by repetitive microtrauma, most common seen in basketball, running, gymnastics, those sports that you're doing a lot of running, especially if you're changing surfaces or if you're on a super hard surface. Now, it's important that if you're supposed to be playing on a grass surface, that your maintenance people or your athletic department puts the money into it to where when you're running on it, that you're wearing cleats, that the cleats certainly go in the ground. If it's so hard, as in golf, we call it hard pan, if it's so hard that your cleats are standing on top of the dirt, then it's just as hard as it is if you're running on the track. So includes weakness. It could be weakness of leg muscles. It could be shoes that provide little support, shoes that are too old. It could be that you actually need some orthotics because you either have a defect that unbeknownst to you, you've got fallen arches, there's so many reasons behind it. But the biggest thing that you've got to do is quit running. All right? And of course, overtraining. I think I've told you this story before. When I was up there in Arkansas at Henderson, the girl came in and she says, I've got shin splints. I said, well, let's look at them. Yeah, you do. You have shin splints. And you play volleyball. How are you getting shin splints playing volleyball? Because volleyball is not an aerobic sport. It's an anaerobic sport. You don't need to have a whole lot of cardio conditioning in order to play volleyball. If you get 15 volleys back and forth, that's a really long volley. It's usually 3, 4, 6, not 15, 20, and one person running around the gym the entire time that this is going on. You're moving into position, you stop moving, you're waiting, you react. So, why are they running 5 miles every morning? And I questioned that, and I said, why are you doing that? Well, coach said we have to do this. Okay, well, how does this help you become a better volleyball player? Maybe you could use that time in the weight room. Maybe you could. But either way, I tell the coach, I say, Coach, this kid has to stop running. Send her to the training room, have her ride the bike, get her on something else. But the running has to stop because these shin splints are only going to get worse. The girl comes back about 2 and 3 weeks later, and this was during a football game. We had a doctor in, and the doctor said, do you have a wheelchair? And I said, yeah, matter of fact, we've got one that's hidden around here somewhere. He goes, from now on, she's in the wheelchair. She actually had to be put in a wheelchair because she had shin splints that were so bad that she was to be complete non-weight bearing. In that time between I saw the coach and the time that she saw that doctor, she was forced into running the 5 miles over and over and over again. She had stress fractures and did not play the rest of that season, and I don't think she played again because of that. I asked the coach one time, I said, Coach, Why did you not heed my advice when I told you that this child should not be running? Well, you're just the athletic trainer. It would have to come from a doctor. Okay, well, I see where you stand. So, shin splint, huh? What you do with that? That'd be a great idea. So, well, possibly. That would be negligent. She had been told. So, it may involve the medial tibial stress syndrome can involve one or two of two syndromes: tibial stress fracture or an overuse syndrome. If you've got 4 grades of injury. One, the pain is occurring after you get done running. And then you have the person that comes in and they have it before and after activity, but it really didn't end, it really doesn't affect their performance. And then before, during, and after, and now it's affecting their performance. If you let them get to that point, you're going to probably see number 4 if they don't stop, which is pain so severe performance is impossible, and they probably already got to the point of stress fracture. So if these don't clear up by taking 2 weeks off or so as far as the pounding, then you've got to get them seen by a physician. And the stress fracture is usually going to show up on a bone scan as opposed to them having to just do an x-ray. So not that because the tibia is so small, it's that the fractures in the tibia are so small. So modify your activity, use the bike, use the upper body ergometer. Correction, you might be pronating your feet when you're walking. You might need custom orthotics. And don't blow off shin splints. Now, the other thing about it is when you're treating shin splints, and you might see them at a track meet, some folks that what they do is they go and they'll tape across here and go all the way around their shin, all the way from the tibial tuberosity down pretty close to the top of their or the bottom of their calf. The thing I don't like about that is that now what I'm doing is I'm setting that athlete up to have cramps. Yes, because if I'm taping this tight enough to hold any of this muscle from vibrating, the muscles in the back are going to be restricted on their blood flow, and now I have ischemia. And ischemia is a reduction of blood flow. You don't want that. So if you just take care of it the way you should, yes, they might miss a track meet or two. Their time might be a little slower, but when they get back, at least they're healthy and they're ready to get serious about it. No, you get muscle cramps. Yes. No, not paresthesia, not the tingling. So it's a serious condition that can have serious consequences. Trauma to the anterior lateral aspect of the lower leg, and we know that's where we get compartment syndrome. So positive signs include tightness to the skin. Oh, this is it. This is compartment syndrome. Positive signs to compartment syndrome: tight skin, drop foot, numbness, can't pick your foot up or down, lose your feeling. So remember when we go back, we saw that picture of that leg? We talked about the compartments in it. All right, this is the one that's up front and to the outside. Doesn't happen a whole lot in athletics, but one of our coaches over there actually had anterior compartment syndrome, not because of him getting hit, but because he broke his tib and his fib. They did surgery, sewed him up, and after surgery, from all of the trauma, the anterior compartment swelled up. They have to then cut you open and leave it open. If you don't, if you don't let that happen until the swelling has subsided, you'll lose your leg. So don't put on an ACE wrap or a compression wrap if you've got an injury to the front of the shin. Get them to a physician, especially if they have a loss of feeling, if they feel like their foot is cold. Well, I mean, their foot's going to be cold if they're walking around barefoot in December. But if their foot feels like, oh my goodness, it shouldn't be as cold as what this is. So the athlete may lose their lower leg if treatment is denied or delayed. All right. You got all these problems. I got shin splints. I've got ankle sprains, I've got peroneal tendinitis, I've got anterior tibialis tendinitis. Holy smokes, you're a mess. So if you pick one, such as an ankle sprain, we'll use a BAPS board, the blue board over here. And the blue board has different balls that go on the bottom of it. So it's called for a biomechanical ankle platform system. And so you put the ball underneath and you're able to move it around. And then you get a bigger ball and you're able to move it in a bigger range of motion until you've got a huge ball. Carol Merrill is bringing this down. And so not only will it do that, but you can get to the point to where somebody could actually be standing on it. And then it'll also not only work on their range of motion, but it'll also work on their balance. So tubing, you've seen tubing, and if it's not tubing, it's TheraBand for inversion, eversion, dorsal, and plantar flexion. But plantar flexion is so easy as far as an exercise because you can just stand there in line at McDonald's. Not that I'm telling you to go to McDonald's, but if you did, all right? Stretching, strengthening, toe raises, functional progression. Functional progression. What's functional progression? It has to do with it's yes, it's functional, so it's something that you're going to do anyways. You gotta crawl before you walk. You gotta walk before you run, and that's what functional progression is. Is we got to teach ourselves how to walk again. Then we have to teach ourselves how to go half speed again, then full speed again, and then we have to do sport-specific things to progress functionally. And of course, you want to take for prevention of re-injury or use an ankle brace. All right, now we're all done with that. So today is just Tuesday.